Good evening, everyone. My name is Celine Gallagher. I'm the chair of the scientific committee of the Australian POTS Foundation. Here in the room with me this evening is Marie-Claire Searley, who's the CEO. On behalf of the foundation, I welcome you all to our webinar this evening, focusing on Ehlers-Danlos Syndrome diagnosis and management. I would like to begin by acknowledging that we are hosting this webinar from the lands of the Kaurna people. I also acknowledge the traditional custodians of the various lands on which you all join us from today, and the Aboriginal and Torres Strait Islander people participating in this webinar. I pay my respects to elders past, present, and emerging, and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands and waters of Australia. We're very excited this evening to be joined by Dr. Fraser Burling, who is a rheumatologist and general physician with a subspecialisation in musculoskeletal medicine and Ehlers-Danlos Syndrome. Fraser trained in New Zealand and graduating in 1993. He has been working in private practice since 2006. He learned musculoskeletal medicine beyond the MSM diploma from Dr. Kenneth Orr, who trained under John Mennell Jr. from St. Thomas's Hospital in London. Dr. Orr combined these techniques with strengthening injections as taught by orthopaedic surgeon George Hackett. Dr. Burling applies these techniques to EDS patients as well, and from there developed the interest in EDS, including discovering that his wife and family are also affected. He now has many hundreds of patients with Ehlers-Danlos Syndrome and is active within the international Ehlers-Danlos Syndrome community, seeking ways to provide even better care for people affected by this syndrome. We're very excited to have you with us tonight, Dr. Burling. I'll let you take over in a moment to begin your presentation. I will ask that all of our attendees submit any questions that they have through the Q&A button, which is found at the bottom of your screen. And we will endeavour to get through as many as we can at the end of tonight's presentation. Thank you, Dr. Burling.
Thank you very much, Celine. Okay, I'll just share the screen. Okay. So, Ehlers-Danlos Syndrome and common comorbidities. So, conflicts of interest. I work in a single centre private practice from which I receive consultation fees. I am on the international consortium for the next hypermobile EDS diagnostic criteria, and my clinic is one of the centres for the study for this consortium's progress in sorting out new criteria. I have received no funding from any drug company in relation to the medications mentioned in this presentation, and I now have over 1,000 patients with EDS. So this presentation is going to be in two parts. First is an introduction to the Ehlers-Danlos syndrome with both adult and the new updated child criteria, which is this year's 2023 criteria for children. Then we'll look at the syndromic aspects of hypermobility, briefly cover POTS, which many of you already know about, and then complications and associated conditions within EDS and dysautonomia. Some treatment options and some examples, and then we hope to have a good amount of time at the end for questions. So if you look at this picture, at first glance you may see horses, but in actual fact they're the shadows of the zebra. Why the zebra? When you hear galloping hooves, don't automatically think horses. And no two zebras have the same stripes. Even in identical twins with EDS, they can have completely different clinical expressions, or phenotype as we call it. Unless otherwise stated, the references for this talk will come from these two journals. So the American Journal of Medical Genetics Part C 2017, March 2017, is the New York criteria, 18 papers in that And then the December 2021 present publication is 24 papers, which is an update on various conditions that have come out since then, which is a really important update. These are currently the effective textbooks for Ehlers-Danlos syndrome and the various conditions that come with it. There has, however, been an explosion of literature that's happened in the last 5 years, from just a few hundred journals to many thousands of publications now. So I will note other publications where reference is needed. So first and foremost, what is hypermobility? People know the Baton score, which is widely used and accepted. And Professor Baton actually only died earlier this year or late last year, if I remember right. Starting with the little finger moving back 90 degrees. Now, if you're uncertain, put the hand flat on the table and lift the little finger up. With the thumb, it's being able to move the thumb to the wrist. May need a little help to do it. You may not be able to do it naturally. I don't know if you can see me, but my hand only goes to 90 degrees. My little finger doesn't go back at all. I'm not hypermobile. The elbow is 10 degrees beyond 180 degrees with the palm facing upwards. The leg is moving, is the knee hyperextending 10 degrees. And if uncertain, you can lie the person down on a bed to check that way. And then it's hands flat to the floor from the standing position. So you get 1 point for the hands flat to the floor, and because everything else is a mirror image, you get 2 points for those, giving a total of 9 out of 9. But you can also have a history of the same, because as people get older, they lose hypermobility. This is an Australian publication from 2017 showing that as people get older, they lose hypermobility. So you can see that 3 to 7-year-olds, at least 80%, well, around 80% have at least 2 joints present. Under 3, it's just not possible to tell. But if someone still has hypermobile after the age of 7, they're hypermobile. In actual fact, the minimum now is 5 as for testing hypermobility in children, because under that, you just can't be sure. But as you can see, as you get older, and by the time that they reach over 70, most people have much, much less hypermobility. Having said that, we still have people in their 80s who come in with a Baton score of 9, but they're uncommon. It's much more to do with the history. We've had patients who at the age of 45 had a Baton score of 5, and by the age of 50, they had a Baton score of 0. They still have EDS, they still have all the other complications and syndromic aspects that go with it, but their hypermobility drops off. And what you often see is someone with a thumb may not reach the wrist, but might be a centimeter away by the age of 50, rather than actually reaching the wrist. I could never get past 90 degrees with my thumb going towards the wrist, and doesn't even when I was very young. So then we have the 5-part hypermobility questionnaire. This was designed by Alan Hakim and Hakim et al. And published in the 2017 criteria. So it's both a sensitive and a specific tool, which is particularly useful in adults who may have stiffened up with age. So if you answer a yes to 2 or more questions, it gives a very high prediction of the presence of at least generalized joint hypermobility. And its sensitivity and specificity has actually been around 80% for both, and you can see the range there. So the first question is, can you now or could you ever place your hands flat on the floor without bending your knees? Can you now or could you ever bend your thumb to touch your forearm? There are some people who say, well, if your thumb can't touch your forearm, you can't have EDS. No, that's actually just 2 points in the Baton score. And 38% of people actually can't get their thumb to their wrist who have EDS. So that's not a diagnostic criteria. It is simply part of the criteria. So as a child, did you amuse your friends by contorting your body into strange shapes, or could you do the splits? Some of the other things we look at is putting a foot behind your head or doing the prayer hands behind the back. I can do the prayer hands in front of my body. No way I can do it behind my back. As a child or a teenager, did your shoulder or kneecap dislocate on more than one occasion? Now, again, only about 25% of people with EDS actually have dislocations. So this isn't a criteria for determining if someone has EDS, because 75% don't dislocate, but it's a good part of the questionnaire. And if it's positive, again, it's a strong indicator that you may have problems. And do you consider yourself double jointed? And many people can do party tricks with their thumbs and fingers and all sorts of things, which, as I say, I can never do myself, but we see it amongst our patients. So hypermobility to Ehlers-Danlos syndrome is a spectrum. It starts off with people like me who are as stiff as a board. Goes on then to regional joint hypermobility, where you may be hypermobile in just fingers or toes, or you might be hypermobile in shoulders and elbows, but not the fingers and toes. Then it goes into generalized joint hypermobility. These are people with a positive Baton score of 5, 6, 7, 8, or 9, but they don't have the syndromic aspects of EDS, so they're not EDS. Then you have the hypermobile spectrum going through to hypermobile EDS. And the cutoff was initially put in order to help look for genetics for hypermobile EDS, because we don't have any known genetics for hypermobile EDS yet. There is an international study happening at the moment trying to find genetics. And it was interesting that 10% of people with hypermobile EDS had one of the genes that are currently known for EDS. 90% were negative. On the other hand, if you reach the syndromic aspects and have the phenotype that fits with the New York criteria for the classical types, then 85% of people will have an abnormal genetic. When you test for genetics, not always COL5A1. COL5A1 is in fact not that common, about 1 in 10,000. But there are 30 known genes, and there are another 30 which are under the microscope because they are associated with people who are hypermobile and have various associated conditions. They may become EDS genes in the future. I remember well, one of my first patients who had genetics done had a B3GAL-T3 gene, which back then wasn't an EDS gene. 2 years later, it was defined as an EDS gene, and I sent her a letter saying, actually, now you have EDS because this is now a recognized gene. So we know that genetics is changing and knowledge is changing. And over time, we're going to find more and more genetics. But right now, we don't know what the genetics are for the hypermobile types. However, people can move along the spectrum from the left to the right, not the other way around. So if someone's on hypermobile spectrum and then they have a family member diagnosed with hypermobile EDS, as you'll see shortly, that automatically changes their diagnosis from hypermobile spectrum to hypermobile EDS. So let's have a look at this criteria. So this is for the hypermobile EDS from the New York criteria 2017 by Francisca Maffei et al. And as you'll see that there are different Baton scores for different ages. So if you're around the age of 6 or 7 or 8, you're expected to have a Baton score of 6. As you get older, the Baton score drops off, and males have an average of 1 point less on the Baton score than females. So again, testosterone firms up ligaments, so males lose their Baton score faster. But from puberty up to about the age of 50, you're considered a Baton score of 5 or more, and over the age of 50, a score of 4 or more. Or, as you saw from the Hakim questionnaire, a history of this. If you reach age 7 and you've got a Baton score of 2, you don't have hypermobility, full stop. You just don't have EDS, because hypermobility drops off quickly in the first few years of life. But if you're at the age of 7, you've got a Baton score of 7, you've got hypermobility. Then we're looking at part 2, which has 2A is a 12-point questionnaire. And it starts off with the soft velvety skin, the soft doughy skin. This is a feeling that you get when you see these people. By the way, people with EDS have one advantage. They always look younger than their age. The very rare exception of very heavy smokers. They've got mild skin hyperextensibility, not enough to reach the classical phenotypes. They have stretch marks, hips, thighs, back, chest, not associated with pregnancy, not associated with being obese, but have come on usually in teenage years during the growth spurt. If you've got stretch marks on the back, that's actually very sensitive, even for someone who is an extra size or a plus size. So you don't normally get stretch marks on the back, even in a plus size person, unless you've got hypermobility issues. Pedicellinic papules are the little lumps that you see around the heels of the feet. They're actually fatty lumps, and you need to have a couple on each side as a minimum for that criteria to be present. Recurrent or multiple hernias, that's actually quite uncommon in young people. Atrophic scarring, these are the stretched scars in 2 or more sites. You don't have to have the 2 centimeters or more, which is present with the COL5A1. In fact, even some people with COL5A1 don't have stretched scars. But even a ½ centimeter or more is abnormal. Most scars are normally fine white lines. The next points from especially 7 to 7, 11, and 12, you don't normally see in children. If you're seeing a rectal prolapse in a child, that's actually a red flag for other serious problems going on. So those are no longer part of the criteria for pre-puberty. However, they are present in post-puberty, and as people get older, they have a greater probability for them happening. But they're still fairly uncommon without pregnancy. On the other hand, dental crowding and a high arch palate or a narrow palate, so dental crowding and narrow palate, or dental crowding and high arch palate, is quite common even at a young age. Arachnodactyly, that's the long fingers, and we see that in people who are marfanoid. So that's where you've got the fingers around the wrist, where the thumb can meet the little finger and cross over, and the thumb through the palm of the hand coming out the side of the palm on the other side. That's the Weber's and Steinberg sign, respectively. Then the arm span to height ratio greater than 1.05. If you have all three present, you're actually really thinking about Marfan's. You need to test the Marfan syndrome in that setting. Mitral valve prolapse is still fairly uncommon. Often it's just a very mild mitral valve problem. And it's still, because it's quite rare, it's only part of the minor criteria. And aortic root dilatation with a Z-score greater than 2. Again, if you've got that present, you've actually still got to be thinking more about some of the other rarer types of EDS as well. But if it's present and you don't have something to indicate further, then it's part of the minor criteria for hypermobile EDS. Feature B, so you need 2 out of the 3 for the criteria 2. Feature B is a family history of a first-degree relative, must meet the criteria. And if someone gets 5 out of 12 in a family member, but the patient in front of you only gets 4 out of 12, the family member getting 5 out of 12 bumps that patient up to EDS if they've also got the musculoskeletal complications. Musculoskeletal complications are pretty common. Why is that? Because EDS doesn't cause injury, accidents cause injury, but people with EDS are more easily injured when they have an accident. I repeat that, EDS does not cause injury, accidents cause injury. We do have this fight in New Zealand with ACC saying, oh, EDS caused the injury. No, the person didn't have pain before they had their accident. They had EDS all their life, but EDS makes you more easily injured when you have an accident and harder to heal. Then you've got point 3, which is basically ruling out the other potential causes. So you don't have the very fragile skin, which you'd expect with COL5A1. If you've got that, then you're worried about a known genetic issue. Exclusion of other heritable and acquired connective tissue disorders. So if you've got something that explains things better, then that's much more likely the diagnosis. And if you've already got confirmed genetics, then you definitely don't have hypermobile EDS. You've got whatever your genetics say. Some people, by the way, can have more than one problem. So I have some patients who have the classical phenotype, but they've got cutis laxus genetics explaining the skin stretch, while they've got hypermobile EDS explaining everything else. So you can have more than one diagnosis. So the new pediatric criteria, this is from Louise Tofts, the Australian pediatrician who headed this paper, but it was still an international consortium paper. And what it's really looking at is for pre-puberty children, you've got hypermobility using the Baton score, and then musculoskeletal complications and or skin and tissue abnormalities and or core comorbidities. And so it really is divided into 8 points, with starting off with all 3 absent, going through to all 3 present as the pediatric generalized hypermobility spectrum disorder, systemic subtype with skin involvement and musculoskeletal complications. When these children reach puberty, then they need to usually be reassigned according to the adult criteria. And these do not include the genetic types. These are for the hypermobile types, which would then become whether are they hypermobile spectrum or hypermobile EDS once they've gone through puberty. So they do need to be reassessed and reassigned criteria once they've gone through puberty and have an adult body. And this is the checklist for the pediatric criteria. And most importantly, if you look down the lower part of the comorbidities, chronic primary pain, chronic fatigue, functional GI disorders, which covers quite a broad spectrum of gastrointestinal issues, functional bladder disorders, dysautonomia, which the people with POTS recognize, and anxiety. Anxiety can often be secondary to not being believed. The #1 plenary talk at the Dublin conference this year was on consultant-associated traumatization, i.e. patients not being believed by doctors. And that was a 2-hour session. And it finished off with an African-American lady who had spent 11 years before someone finally told her that her chest pain and shortness of breath was not just in her head, and actually did an ECG and an echo, and she was found to have a cardiomyopathic EDS on genetics. But to take that long before someone believes you is a major cause of traumatization. How common is hypermobility? So between 2% and 57%, depending on the population. And that's because different studies are looking at different groups of people. You'll find that people with POTS have a much higher chance of being hypermobile. However, just looking at the general population, 1 in 50 people in the general population are considered to be hypermobile. Compared to that, say vascular EDS, which is the rarest, where it's 1 in 75,000 to 1 in 150,000. And yes, of my 1,000 patients or plus that I have, only 6 have confirmed vascular EDS genetically. Classical EDS, so the COL5A1, for example, it's about 1 in 10,000. Hypermobile EDS is 1 in 500. So only 1 in 10 people who are hypermobile actually fit the criteria for hypermobile EDS. So hypermobility does not equal EDS. You need to have the syndromic aspects before you have a diagnosis of EDS. And as noted, hypermobility does reduce with age in most, but not all people. I had one lady at the age of 82, she could still bring her foot right up to her head, lying flat on a bed. So, skin stretch, does it matter? And if so, how much? So this is again, it's straight out of the New York criteria. For the classical phenotypes, one needs a minimum of 3 centimeters in the neck, 3 centimeters from the back of the elbow, 3 centimeters on the knee, usually taken just on the top of the knee above the patella, 1.5 centimeters from the back of the wrist, 1 centimeter from the palm at the thenar eminence. And if you get a clear ruler, you can actually measure this easily. You just pull on the skin, pinch on the skin with a ruler, put the clear ruler right up beside it. Remember, the clear rulers usually have a 0.5 centimeter before they start the measurement, so you count that in your calculations when you're looking at the measures. If all 5 are present, then 85% of patients will have some abnormality in their genetics. This is what our international colleagues find. This is what I found in my own clinic for those who've had genetics done. If 4 or less are present, then 90% will have negative genetics, according to the current known genetics. And that's because we don't have known genetics for hypermobile EDS yet. Vascular type usually has less skin stretch, so it doesn't have the same degree of skin stretch as those seen in the other classical types, but it has other red flags instead. And I won't go through that criteria today. It's easy to look up if you want to find it or if you suspect it. But most importantly, if you have someone who's got an unexplained dissection at a young age, or if they've got a family member who dropped dead from a vascular bleed, you've got to check out what's happening with them with genetics. So let's have a look at the syndromic aspects now. So there is this increased risk for injury. And I repeat, EDS doesn't cause injury, accidents do. And there is delayed and or impaired healing. It's much more common to be slower healing or incomplete healing. When you have the allied health people provide input, it needs to be gentler. When people get the deep tissue massage, especially with those who will use their elbows on the deep tissue, if they're doing it on the back, they can actually cause rib injuries. So it must be gentle. Osteopathic and chiropractic treatments can still help these people, provided they're not overdone. So if you've got a chiropractor who says you need to come back for 3 times a week, don't go back to them. If you've got a chiropractor who says once a fortnight and says come back when you need it, that's much more like the osteopath. They're usually very good. And you need more gentle recovery from surgery. And there are other issues associated with surgery, which I'll come to later. So dysautonomia, which is at the heart of the POTS people, you get low blood pressure issues. Why is that? Because you have increased peripheral vasodilation, because the blood vessels are more lax. The collagen around the vessels are more lax, and so you get more blood pooling in the legs. Therefore, when you get blood pooling in the legs, you get low circulating blood volume. And then you have medications which can make it worse, such as your tricyclics, which are used for pain relief. You get increased adrenaline running around the body trying to compensate. You've got issues with mast cell autoimmunity, antibodies directed against receptors, which play a role in the regulation of heart rate and blood pressure and other autonomic functions. And the dysautonomia and mast cell issues can cause excess levels of histamine, which have a huge feedback on the vascular system. Rarely you get other problems such as brainstem or cervical cord impingement with Chiari malformation or craniocervical instability. Craniocervical instability isn't quite so rare, as certainly nowhere near as rare as Chiari, and it's actually much more easily treatable now. So triggers, we know about medication side effects. Dehydration is an obvious one. Hot environments. If you're in 30 degrees temperature, you're going to have much more peripheral vasodilation trying to evaporate sweat from your body in order to stay cool. Exercise or after exercise. So some people drop their blood pressure after they've exercised because when you're exercising, your muscles act as a pump pushing blood back from your legs back up to the heart. Doing the Valsalva maneuver, lifting a heavy object, going to the toilet and straining on the toilet. A big issue for people with constipation, and with EDS patients, you can go 6 weeks between a bowel motion in some patients. It can be that bad. And yes, I have patients who are like that. Alcohol and caffeine both dehydrate because they make the kidneys push out either the alcohol or the caffeine into the urine. After eating, you get the blood rushing to the stomach and the small bowel and large bowel trying to digest food. So that can also take blood away from other parts of the body. Obviously, infections vary from mild infections like a sore throat through to septic shock, where it doesn't matter whether you have EDS or not, you've got major circulatory failure. Stressful situations, so someone taking a blood test faint, someone seeing blood either around them or even on the TV can cause their blood pressure to drop. Having an argument, getting hot and flustered, sitting exams, especially when you've got the adrenal overdrive beforehand. Pain stimulates the body to pump out adrenaline in response to pain. But if you're neither running nor fighting, which is what the adrenaline's meant to do, then the blood pools in your legs where it's aiming to help the muscles, and it's therefore not being pumped back to the heart, and you drop your blood pressure. High altitude. People who also notice when there's a low over the country, because the low pressure system affects the amount of fluid in the bloodstream. So when you're in a low pressure system, which can be either at altitude, so when you get altitude sickness, you get fluid coming out of the bloodstream into the soft tissues. When you come back to sea level, the fluid comes out of the soft tissues back into the bloodstream. And we see that happen when people have come off an airplane from a long flight, a 14-hour flight, and they're very short of breath, and you do a chest x-ray and you see their lungs are whited out, just to see that, as you can see, the same thing happening with altitude sickness. If you're up at 3,000 or 4,000 feet, some people are 8,000 or 9,000 feet before they start to get symptoms. After long periods of rest, and this is from deconditioning, surgery involving general anesthesia. General anesthesia can knock the body around quite a lot. And then allergic reactions. We'll come more on that in a little bit. So, touching on the syndromes. People with EDS metabolize medications differently. Often need 2 to 3 times the dose of anesthetic just for a dental procedure. Yes, this is real. And they'll chew through that anesthetic much faster. So instead of lasting an hour and a half or 2 or 3 hours, they can go in 15 minutes. They have a greater risk of waking when under a general anesthetic, and so they can need 2 to 3 times the dose of a general anesthetic to stay under. Unfortunately, then they can stay under a bit longer and take it longer to wake up afterwards, but they need that extra anesthetic in order to stay asleep. They can, however, still break down anesthetic faster than normal, and that's because of its redistribution out of the fatty tissue into other parts of the body as well. They can bleed more easily. So there is actually a significant bleeding risk in people with EDS, especially with general surgery. And I now have a form that I can give my patients, which notes to the surgeons and the anaesthetists about this. DDAVP, or desmopressin, so I've mixed it's DDAV, not DDVA, DDAVP, or desmopressin reduces the risk of bleeding from a major bleed from 30% to 0% in the studies published, as noted in the 2017 publication. I'll repeat that, reduces the risk of a major bleed from 30% to 0%. There is a tiny risk with DDAVP for low sodium levels, and so I make sure the patient gets a sodium level 24 hours post-procedure, and if it's low, treat it with a saline infusion. Saline is much, much safer to the body than a blood transfusion. Vitamin C, the New York criteria recommends 2 grams per day as a minimum. 4 grams a day is often recommended in people with the vascular types. But vitamin C reduces bleeding overall. Why is that? You need vitamin C to produce collagen. So vitamin C is needed in at least 5 different aspects of collagen production. Obviously, and if you're low in vitamin C, you get scurvy, which still happens in first world countries like Auckland in New Zealand. And I have seen a patient with scurvy. A diet of chippies, chocolate, and Coke for a 5-year-old child was not sufficient to provide vitamin C, and so she had scurvy. So I said to the parents, you need to have fruit and vegetables and vitamin C. So, but even a small drop in vitamin C can cause more abnormal collagen production. So if you've already got abnormal collagen production, then you need extra vitamin C so that your collagen is produced at the optimum you're genetically capable of producing. So that's why there's this recommendation of a minimum of 2 grams or 2,000 milligrams a day. There is increased risk of dysautonomia, as we've mentioned. So the POTS syndromes and the orthostatic hypotension and just generalized dysautonomia, which is where you've got the supraventricular tachycardia that can happen regardless of whether you're lying, sitting, or standing. Medications we'll review later, but there's also, because of this, a greater incidence of migraine and fainting in people with EDS and POTS patients. A lot of that migraine has got to do with neck problems, and a lot of it's got to do with mast cell problems, but it's also got to do with how the body deals with problems of the vasodilation followed by vascular spasm, and migraine's about vascular spasm. Temperature dysautonomia and dysregulation. So people with EDS often feel hot on cold days or feel cold on hot days, and they might be shoving on clothing when everyone else is losing layers, or they might be losing layers in the middle of winter when everybody else is shivering and shoving on layers. And they often have temperature swings from moment to moment. We don't have a good medical treatment for this, or we can tell patients at this stage is to carry different amounts of clothing with them so that they can adjust themselves. It's not been formally studied yet, but it is noted in your criteria and frequently seen in my patients. Probably more than half my patients have temperature dysautonomia or dysregulation. Gastric issues. So there is a marked increase in gastrointestinal issues, and we're really just going to touch on this because this can be a whole talk in itself. And in fact, it can be a whole session at conferences in its own right. Gastroparesis. So this is where the stomach can't break down food easily. You'll have patients where they'll take a steak and eat it, and then 8 hours later, they vomit up the steak and it looks completely unchanged. They've got significant gastroparesis. Steak is, by the way, one of the worst, which is why I note that as an example. And what these people do is they find it's much easier if they have blended foods like soups and smoothies. And but if they have anything that's solid, then it's hard for their stomach to break down. There are easy investigations to look for this, but you have to get someone who's willing to actually do the investigation first, and that can be a little harder to find. However, if you find it, then the treatment is, apart from soups and smoothies, if that's not enough and they're still struggling, then either nasojejunal or percutaneous jejunostomy feeding can make a huge difference to the quality of life of these patients. However, they don't always come alone. So they may have problems with swallowing food before they get to that stage. They may have small bowel dysmotility, and they may have large bowel dysmotility. The large bowel dysmotility can be so severe that their bowel is clogged up with feces, and they end up with a completely non-functioning large bowel. And sometimes they need to have a stoma, which is bringing through part of the bowel to the stomach wall so that the feces can come out into a bag instead. And bypass the area which has stopped working properly. They can still have constipation up to 6 weeks between motions before they reach the stage of having a bag. Sometimes that constipation can happen because they're only having such a small amount of food going in that they're actually digesting and absorbing most of the food, and so not much actually reaches the large bowel to pass out. So these are the people who you think, how can they be alive and living when they're taking such a small amount in, but they're processing the food at a different way than what most of us do. Conversely, they can have diarrhea, up to a dozen loose bowel motions a day. And they have a very short transit time instead of a very long transit time. And that can be a little harder to treat. But we often find that that's due to mast cell issues or immune hypersensitivity problems. And then you've got those who can alternate between constipation and diarrhea. Sometimes they'll have constipation with overflow diarrhea, which gives the IBD symptoms. And other times they will still actually clear out properly when they alternate between constipation and diarrhea, but they have a fluctuation that's more over weeks rather than over days between the two. Then we have ARFID, avoidant restrictive food intake disorder. This is not anorexia, this is not bulimia, but it's often confused as such. Anorexia and bulimia are usually associated with image or control or ways of dealing with abuse, such as sexual abuse at a young age. And these people will be secretive about it, so they don't want people knowing that they're doing this. They'll often give themselves as a fat image when they're very slim, as opposed to ARFID, where the people are desperate to take food in but can't, because any time the food passes their mouth or reaches their stomach or reaches the small bowel, they have severe pain. They want to put on weight, but they can't because of the severe pain. Completely different underlying pathology. ARFID is a very significant pathological problem, whereas anorexia and bulimia have a major psychological component. So they're not the same thing, then they shouldn't be confused as such. We do have patients who've had anorexia or bulimia, and then a couple of years later, they get on top of that, and then they develop ARFID. And they often get told, oh no, this is your anorexia back. No, actually, it's really ARFID. It's really painful for them to eat. And there are many causes for that pain, which include gastroparesis, small and large bowel motility. But there can also be the next issue, which is vascular compression syndromes. Median arcuate ligament syndrome, superior mesenteric artery syndrome, May-Turner, and Nutcracker. So what are these syndromes? On the top left, we have the SMAS and Nutcracker. So you can see on the very leftmost picture that you've got the aorta coming down and the superior mesenteric artery coming off at a 45-degree angle. I don't know if you can see my pointer, but it comes off at a 45-degree angle. And the left renal vein, which sits just underneath it, is nicely rounded here. And then below that, you've got either the third part of the duodenum or part of the jejunum, which sits underneath. Problem is when that angle is squashed, for ligament slipping is one of the common reasons. And the left renal vein gets squashed, which is the Nutcracker syndrome, and the duodenum gets squashed, which is the superior mesenteric artery syndrome. Why does that make a difference? So the left renal vein also has a vein that comes into that feeding from the spine called the tronc-reno-rachidian vein. And that backflow caused by the squashing of the left renal vein can cause swelling around the spinal cord and even cause people to be wheelchair bound and as a result of the pain and start to lose sensation in their feet. When the duodenum is squashed with the SMAS syndrome, food can't get through. Sometimes a tiny little bit of liquid gets through, but everything backlogs. And these people won't be vomiting up just stomach contents, they'll be vomiting up bile as well because it can't move forward. And it's extremely painful for them. When you've got MALS, the median arcuate ligament, which is the top right picture. So the median arcuate ligament in the normal anatomy sits higher up over the aorta. But when you've got MALS syndrome, the median arcuate ligament has slipped, which you can see is the lower band of brown that slipped down over the celiac artery and starts to squash that down. And if it goes far enough, it can also squash the superior mesenteric artery as well. And then at the bottom part, you've got the May-Turner syndrome, which is where the artery splits into the common iliac arteries and overlies the left iliac vein and causes compression of that. And that can cause major pelvic compressions, congestion, and pelvic pain through that congestion. Treating these, if you only treat one of them and don't treat the others, the person will still have ongoing pain, still have ongoing problems, will still have ongoing ARFID. And so if you're going to treat one, you actually have to treat all of them if they're all present. And in New Zealand, we've had at least a dozen patients who've gone to Germany to get the 3 or 4 that they have treated. And Wilhelm Sandman's the vascular surgeon there. And Thomas Skolbach is the physician who's defined a protocol to help look for all 4 in patients. If you've got a good radiologist who's willing to follow the Skolbach protocol, then it's much easier to see. And if you're still uncertain, they will actually read them for you if you send the images to them. They'll do that for a small fee. And then they can help direct you as to what you may need. Bladder and uterus. So people with EDS can have a stretched bladder and hold on all day long. It's not good for them because it can reach the stage where they end up having to be self-catheterizing and in the extreme cases needing a suprapubic catheter. So I do recommend to them, you might feel like you can hold on all day and it's good if you're going out, but you still need to pass urine at least 3 times a day so that you don't overstretch the bladder. Conversely, they can have urine frequency, feeling like they've got a urinary tract infection, but no infection is present when testing is done on urine. And this is usually due to immune hypersensitivity on mast cell processes going on with a major histamine release issue. And we find that when we treat the mast cell issues, the urine frequency settles down very nicely. They have increased endometriosis. The 2021 papers noted that endometriosis is 5 to 8 times more common in people with EDS than people without. And women can even react to their own periods with a mast cell reaction, which was noted in the Internal Medicine Journal in 2015. Pregnancy. It can be slippery fast or complicated. It is rarely in the middle. So when I've asked my female patients who've had children, most of them are slippery fast. But if they go past 12 hours, then all bar one has gone on beyond 24 hours and either had a very complicated delivery or needed cesarean section. For those who didn't get the cesarean section, they have a very high probability for prolapse, whether it be vaginal, uterine, or rectal prolapse. And that's because of the complications. So if someone's gone past 12 hours and they have known EDS, I say, make sure your surgeon's there ready for knife to skin at 24 hours, because they normally don't do cesarean in the first 24 hours. They try to let the labor progress naturally. But you shouldn't be waiting much beyond 24 hours. If you reach 24 hours, you know you're going to need to have a cesarean. Otherwise, your risk for complications, especially prolapses, rises exponentially the longer you leave it. So I keep stressing this to patients. Make sure your gynecologist obstetrician is aware of what's going on with you, and so that if there are complications, that they head to cesarean early, not late. So, immune hypersensitivity and mast cell issues. These affect 2/3 of people with EDS according to the New York criteria papers. That's increased asthma, eczema, hay fever, skin rashes from any cause. That includes dermatographia, hives that come on out of the blue, rashes from maybe gluten or dairy intolerances or other drugs. They often have a long list of drug allergies. Urine frequency, as we mentioned, can be mast cell issues. The bowels alternating between constipation and diarrhea or just plain diarrhea. The endometriosis flaring the mast cell issues. And often they will have a situation where they have pain the whole month long, not just at the time of their period from endometriosis because it gets so bad. In that situation, settling down the system by switching off periods with hormone replacement therapy is a good way of helping to reduce that continuous month-long pain. Other food allergies as well, and yes, multiple drug allergies are common. Just if I can go back, mast cell issues are often under-recognized in patients, especially when they cause other problems. So one of the causes of severe abdominal pain, when it's occurring 20 minutes after eating rather than 5 minutes after eating, can be a mast cell issue. And I'm going to mention a little bit more about mast cells later, but it's important to note that mast cells are the first line of the immune system for white cells against foreign objects. So mast cells sit under the skin whether it be external or internal skin, anywhere that's exposed to external area. So anywhere through the gut as well. And when you've got exposure to a foreign body, mast cells can react in under a second. Neutrophils can react in minutes, and lymphocytes can react in days. But mast cells can react in under a second, and they have a long list of things that they produce, and I'll come to that soon. Psychological problems are common in EDS, but they're commonly secondary. Anxiety or depression, anxiety from not being heard by doctors, being told it's all in your head. It's not in your head, it's real. Depression, pain is a major depressant. If you're living in chronic pain, there's a high probability you'll be depressed by it. Funnily enough, when you remove the pain, the depression lifts, and it lifts very quickly. Post-traumatic stress disorder, also known as consultant-associated traumatization, when it's doctor-induced, is a common problem and commonly caused by doctors. And the best way that we can deal with this is to provide a listening ear and to be there to listen to our patients, to hear what they have to say, not just dismiss them out of the hand and say it's all in their head. As mentioned, secondary eating disorders from Ehlers-Danlos syndrome, not anorexia or bulimia. The risk of anorexia and bulimia is actually no greater risk than in the general population. And anxiety and depression, primary anxiety and primary depression are no more common than the general population. Secondary, they're very common. On the other hand, ADD, ADHD is 5 times more common in EDS than the general population, and autism spectrum is 5 times more common than the general population. Both of those from the 2021 publications. Delayed physical development is common. So this is physical, not mental, not intellectual, but physical development. And it's because you've got laxer ligaments that take a bit more muscle strength to control them. So there is slower gross motor development, and there can be slower fine motor development as well, including writing skills. Slower developmental coordination. So you get DCD, or developmental coordination disorder, slower to catch a ball. Slower to do simple things, which others would say it's like riding a bike. You can find these people, and this not just children, but adults, can walk down a hall and walk into the wall when they're supposed to be walking down the hall. Or they go through a doorway and hit the doorpost. And this is because there's also a decrease in proprioception. This can be helped with wearing skin-tight clothing, so you've got a different way of adding to proprioception feedback. And if you put them in skin-tight clothing, they'll walk down the hall and not walk into the wall, and they'll walk through a door and not hit the door frame. If you've got issues with writing, the overlaid ring splints are great for stopping the fingers hyperextending and go from a grip writing through to the standard 2 or 3 finger writing. Just a short spell on treatment for POTS, because that is slightly different from general, but there's a few important things to note. So first and simplest is avoiding and reducing exposure to triggering factors. On the right, you'll see my homemade sports water. You take a liter of water, add a teaspoon of salt, a tablespoon of honey, and lemon juice to taste. And it tastes like old-fashioned salty lemonade, which many people find very nice. Some people are actually allergic to honey if they've got severe mast cell issues. So it's not for everybody, but it is for many people. If possible, withdrawing medications that might worsen symptoms. Not always easy to do, because sometimes they need those medications for other reasons. Maintaining good hydration is important. Extra salt. There's a meme that runs around on Facebook with a girlfriend, boyfriend who are out, and the girlfriend asks for extra salt on her potato chips. Next, she's asking for extra salt on her ice cream. Then she's asking for extra salt on something else. And finally, she has a salt shaker in front of her and says, needs more salt. And by that stage, the boyfriend has a sigh of a look of resignation on his face. But it is true. People with EDS crave salt, and they're doing so to help their blood pressure. The message that came through in the 80s and 90s on reduced salt is important for people who have hypertension where mortality follows what we call a J-shaped curve. So too little salt increases mortality, but too much salt increases mortality, increases exponentially with increasing amount of salt. You don't see a J-shaped curve for people with EDS. You see the first part of the J, too little salt increasing mortality, but the second part is almost a flat line with increasing salt because they're needing salt to help their blood pressure. So craving salt is there for a reason. Reducing venous pooling by elevating the legs or by abdominal or lower limb compression garments. The only thing is, people don't like compression stockings. They're hard to put on and they're not fashionable. Sports tights are much easier to put on, much more fashionable and much more likely to be worn. And they go up over the lower abdomen as well, which can also help in some of those people who have a degree of Ehlers-Danlos syndrome. And so it's providing more pushing of the fluid back through the veins. Increasing exercise adapted where necessary for the presence of hypermobility, instability, and injury. Lack of exercise is bad for everybody, including people with EDS. Some people are so deconditioned, though, that they've got to start off with exercising horizontally to allow their blood pressure to not go collapsing into their boots compared to if they're exercising upright. And then they go graduated to exercising with sitting and then exercising with standing. And you do small amounts often, not a large amount at once. You do 15 minutes at once when you haven't exercised, you'll crash and burn for the next 3 days and you end up worse off. If you're, however, doing 2 or 3 minutes, 3 or 4 times a day, you can build up gradually until the point where you can do the 15 minutes once a day. But you've got to do small amounts often and build up. And you've got to go at the pace that the people with the EDS are able to hand relevant to the other injuries that they're suffering at the same time. Gentle physio. Muscle relaxation is just as important as muscle contraction, especially in people with EDS who dislocate regularly. So there's some people with EDS that dislocate the shoulder 10 times a day. And where we've helped them is with strengthening injections and prolotherapy that stops dislocation. And we published that in 2019 in the BMJ group. If you want to look that up, it's just Google BMJ plus Burling and it's the first hit. However, what they often do is they'll have one group of muscles that's really tight and will spasm the joint out because it's trying to compensate for the lax ligaments. And then you have a compensatory laxness on the other side. So physio, part of the importance of physiotherapy is to help the tight muscles relax, just as much helping the relaxed muscles to tighten and do their job properly. In EDS, the ligaments are loose and the muscles are tight, but in the normal population, the ligaments are tight and the muscles are loose. So putting a dislocated shoulder joint back in a rugby player takes a lot of effort, putting them in a specific position and straining hard. Someone with EDS, you can put a dislocated shoulder joint back in 30 seconds really easily until you tighten up the ligaments. Sleeping on a slope so that you've got the body's autonomic system working night and day can help. Having small frequent meals rather than a large meal at once so the blood's not rushing all off to the abdomen and leaving it everywhere else desperately wanting it, like the brain. Again, gentle exercise, low weights, supine. In pools are great. The only problem with exercising in pools is when you get out, because all that lovely pressure of the water that's been pushing the blood up has suddenly disappeared, and you can find yourself in trouble when you get out of a pool with the blood pressure going low. Small amounts often is really important. Exercise, have extra fluid, sports drinks. You'll often see people walking down the street with a big water bottle in their hand, and because they're sipping on it every 5 minutes, and that's their way of helping to keep their fluid intake up. Try and avoid food within an hour before exercise, but that's not always possible, especially if you're having small amounts often. And gentle cool down exercises so that you don't have that big rush to the extremities when you're trying to let all the excess heat escape and find yourself with the blood pooling and away from the heart and therefore away from the ability to get back to the brain. Medications, the mainstream, you've probably heard from many people before: fludrocortisone, midodrine, beta blockade. A little note about that. Metoprolol can cross the blood-brain barrier and has a slightly increased risk for depression, whereas nadolol is slightly less effective peripherally, but doesn't cross the blood-brain barrier and so therefore doesn't have that same risk for depression. In New Zealand, we have to get the cardiologist to prescribe aberdeen in order to get funding for it. Then we've got a few more medications which can provide extra help. Stimulants for people with ADD, ADHD can actually help raise the blood pressure in some of our patients, which may sound counterintuitive for some of them, but in actual fact, it works very well for some of them. Oral contraceptives to reduce the amount of blood loss when you've got flooding with menstruation. DDAVP can also help the blood pressure, but please watch the sodium levels. Saline infusions. There are people who think, well, saline's gone from the body in 24 hours, but in actual fact, it has a prolonged benefit on the body. Some people struggle to absorb fluid, but if you give them a saline infusion, it seems to rehydrate the bowel and then allows the bowel to absorb fluid much more easily over the next 4 to 7 days, up to 14 days. And so some people need a saline infusion once a week or once a fortnight, and they may only need it for 4 to 6 months, and then they don't need it again for a while. So don't begrudge it, and it is noted in both New York criteria and a number of other publications now. Pyridostigmine, which has been used for myasthenia gravis, can also help when people have impaired colonic dysmotility or constipation, and that can also help feed back to allow better blood return back to the heart. Clonidine is used for central hypernergenic POTS and octreotide for those with postprandial hypotension. I've not had any patients on octreotide in my career so far. So what's happening with mast cells? Firstly, the question which many people ask, are zebras black with white stripes or white with black stripes? The answer is zebra has a black skin with an absence of melanocytes in the white hairs. So I give these slides a courtesy of James Cousteau, who's an Englishman who did who's a psychiatrist, but actually has done some excellent work on this. So CRH, also known as corticotropin releasing hormone, is present in mast cells, and mast cells have receptors for this as well. Substance P, which is also released under stress, increases the CRH receptor expression on mast cells. Mast cells produce and secrete corticotropin releasing hormone, and in fact, more CRH is produced by mast cells than by the hypothalamus. And you can see on the right, normally the hypothalamus produces the CRH, causing the pituitary to produce ACTH, causing the adrenals to produce cortisol and adrenaline. High CRH levels have been associated with mastocytosis, psoriasis, and atopic dermatitis, which helps support the intimate association with CRH and mast cells and mast cell activation. CRH has a role of regulating the blood-brain barrier permeability, which is really important because when it's released under acute stress, it stimulates mast cells, and together they regulate the blood-brain barrier. CRH binding to mast cells leads to release of vascular endothelial growth factor, VEGF, which is released selectively without degranulation and is vasodilatory. It's also released with degranulation of the mast cells as well. So vasodilatory, opening up blood vessels, more blood vessel pooling, more POTS issues. So here you've got this shown in a summary. On the left, you've got the blood vessels. You've got mast cells that sit in the walls of the blood vessels. They also sit in the walls of the bowel. You get a stimulation either from the hypothalamus or from the mast cells, which then stimulates pro-inflammatory effects, with increased fatigue, increased cardiovascular dysfunction, cognitive impairment because of impairment of the blood-brain barrier, and increased pain. So treating mast cell issues often helps POTS. Avoiding the triggers where possible is important. Antihistamines, the #1 stay for treating a mast cell activation, i.e. asthma, eczema, hay fever, hives, etc. But people with EDS can actually get aware of effects so that they'll be on one antihistamine, such as loratadine or cetirizine or fexofenadine, for about 6 months, and it stops being effective. So they have to switch to the next one, and that'll last about 6 months before it stops being effective, and then they have to switch to the next one. And that'll last 6 months before it stops being effective. And then they can go back to the first one again. And that's good for another 6 months. And so they just rotate through all the three. You don't have to go to the more expensive newer agents. Sodium chromoglycate is a good mast cell stabilizer. It is very safe. Apart from people who have extreme lactose intolerance, and I have only a couple of patients who have to get it compounded through compounding pharmaceuticals in New Zealand, but compounding agents in Australia can do the same thing. But it's so safe that if a child overdoses on a bottle of it, they don't get sick. And it's been used in children for decades as a treatment for asthma. And it's mainly the asthma that's issued from mast cell problems. So it is a very safe treatment, and it works in about 2/3 of people. It can take 6 weeks to kick in. What that means is that some people don't realize it's having a benefit, and after 6 weeks to say, oh, it's not working, they'll stop it. And a week later, everything flares. Okay, it was working, they go back on it again. However, if they stop it and there's no difference, then they know it's not working for them. So we're going on to the next option. Montelukast is second line in New Zealand because it's still funded, but it has a tiny risk for depression. And so you need to warn patients about that. Again, it has lactose in it. The current form that we have here helps 70% of people, and that's Montelukast Mylan. The previous version we had before that was Montelukast, which helped 90% of people, but that was taken away from New Zealand in 2019 after the husband and wife team who set up the APO company were murdered. Unfortunately, that still happens in the American continent. And so we have a less effective agent. In Europe and in England especially, ketotifen is first line because it helps more than 9 out of 10 people. But in New Zealand, it's not funded. And I think in Australia, it's not funded either. So you have to get it through either some funding agency or have your Medicare cover it. If you still have problems with those, then there are stronger agents that we use, which are used as disease-modifying anti-rheumatic drugs for other inflammatory conditions, and they can also be used to help mast cell issues. Then there's the biologic omalizumab, and I always have immunologists prescribe those drugs. So some unusual effects of POTS in EDS patients. And the examples I'm about to give, I have consent from the patients and their families for providing this information. So they can have unusual effect in children. Children may have anxiety. They may develop obsessive compulsive behaviors. They may develop tics, pauses, mood swings, even rages, and they have no idea what's going on. But that's because they get the adrenal overdrive when the BP is low. They can struggle to learn or cope with school. And this isn't a lack of intelligence. This is because they've got medical issues that are affecting their ability to concentrate and to learn. They can have late enuresis, so bedwetting up even to the age of 20 occasionally, so way beyond the age of 7. And they're often told they have a functional disorder or worse, a factitious disorder, when in fact, they've just got a misunderstood or a not understood process that's causing their problems. So let's give some case studies. Patient 1. This is a male who at the age of 8, he'd been diagnosed with a genetic type of EDS only a year before. First, he developed tics, and then he developed obsessive compulsive behaviors, washing his hands continuously, starting to have little mantras. Then he had some swallowing issues, not swallowing his saliva properly. Then he started having pauses, and this was an issue for the family because he'd be walking down the street and pause for 5 minutes. More of an issue if he was walking across the road and paused. And then later he started to develop bladder and bowel incontinence. So this was a major problem, but it got worse. He developed rages. He had some insight in that he didn't know what he was raging about. And his mood improved when he was lying down, but it worsened when he was standing up. It came to a head when he'd been overseas and had rages while he was in a hotel, and the family were worried because people were gathering out on the street wanting to call the police. So he was sedated and brought back home. He was then taken to a psychiatrist who recognized it was not a mental illness. And so he didn't cause harm by saying it was all in your head, but admitted that he didn't know what the cause was. It was then just a few weeks later, when he was having one of his pauses, that his pulse was felt, and it was 150. That was the breakthrough. He was treated with beta blockers, and the improvement was almost instantaneous in all aspects. It was really dramatic change. The only setbacks he had was when he'd forgotten his medication. And then an hour or two later, the parents would say, have you taken your medication? Oh no, forgotten. He'd go and take it. And in the last 5 or 6 years, he's done incredibly well. However, he had one other issue that came up. He just started developing symptoms of a urinary tract infection. Now, males don't normally get urinary tract infections because there's such a long tube between the bladder and the outlet compared to females. However, by this stage, in view of this EDS, he was given a trial of antihistamine and symptoms went away in just 20 minutes, which was the absorption time of the antihistamine. So he was subsequently treated with mast cell stabilizers, and he's done incredibly well since. Patient 2, a female aged 13, had a diagnosis of hypermobile EDS, and when she initially arrived at the clinic, she had profanities with her tics. She had mood swings that started before menarche, and a pulse went from 72 to 144 from sitting to standing. Didn't need a lying to standing pulse or sustained. It was still sustained out at 5 minutes. And as a cardiologist here noted, Fiona Stewart, if you go to 5 minutes, then you're going to be positive at 10 minutes. And she's shown that in some studies of her own. Put on a beta blockade, and again, a dramatic turnaround in symptoms, and the tics stopped instantly. The mood stabilized, and she's not needed to be seen for 3 years now. The third patient is male, aged 13 when he was first seen. He couldn't study at school. He couldn't think straight. He had an infantile speech which had developed in the 6 months prior to coming in. He had reported auditory hallucinations. And was told by a neurologist that he had functional neurological disorder as a mechanism for avoiding school. He wanted to go to school. He had chronic migraines as well. So in the clinic, his pulse rose 60 points from sitting to standing. He had a joint dysfunction in his neck that was found and released. He was started on beta blockers, and his speech normalized. His migraine settled with a combination of release of stuck joints and prolotherapy. And he was back at school and loving it. And most importantly, the parents are extremely grateful at having their child back, which is a common theme that we see when we're treating these children with these issues. We've even had some adults who noted that they still get periods where their mood swings and they can't work out why. And you treat their POTS, and lo and behold, things settle down again. And they are also very thankful, as are their partners. So, in conclusion, if you can't connect the issues, think connective tissues. I'd like to thank the Australian POTS Foundation for inviting me to speak, to my wife and family for their unending support for me on this journey of discovery, to my patients and their families and their consent for presenting these cases, and to the EDS Society, especially to people who are now called good friends, Alan Hakim, Claire Francomano, Heidi Collins, Larry Afrin, Lara Bloom, Peter Byers, Fiona Stewart, James Cousteau, and many, many more who have been helpful. So, questions and discussion time. I'm just going to stop sharing.
Thank you very much, Dr. Burling, for a fantastic presentation. It was very informative, and I'm sure everyone will agree that we've learned a lot. We've had lots of questions come through on the Q&A, so we won't be able to get through all of them, but we'll get through as many as we can. So first of all, going back to the earlier part of your presentation, somebody has asked about accessing genetic testing. And is there a reputable private company that can be accessed to undertake this genetic testing?
Excellent question. We use Invitae, which is American-based. They have a subsidiary in Sydney. The cost for a connective tissue panel, which is a 92 gene panel, which includes 28 of the 30 known EDS genes, is currently US $349. You can get a saliva test kit from them. And if you do the salivary test kit, please follow the instructions properly, that if you have any food in the last hour, it's going to upset the results and give an incomplete reading. And so they won't be able to analyze it. It's best done first thing in the morning when there's been no food in the mouth at all. So the salivary test kit works in 19 out of 20 people. If you fail the salivary test, they won't charge you extra because they only charge you when they're ready to give the results out. If you pay for it personally, it's $349. If you have an institution pay for it, it's $1,200 US. So just a little warning there. get it done privately rather than institution pay, especially if you then have to pay the institution. The results aren't always EDS genes. So we do have other abnormalities. As I mentioned before, we have a couple of patients who've got cutis laxus with hypermobile EDS, where they've got a classical EDS appearance. Some get Stickler syndrome. A few have Loeys-Dietz syndrome. We've also got other things that we've come through as well. So there's another 30 genes which were presented in last year at the scientific conference that are now under the spotlight as causing connective tissue issues that can give a picture similar to EDS. So anything where you've got a variant of uncertain significance, VUS, or stronger is certainly worth looking at. A VUS means that there's not enough knowledge to know whether it's a pathological gene or not. And it takes a little bit of effort to try and work your way through that. Sometimes it means testing family members, and Invitae will test 2 first-degree family members free of charge for some of the genetic abnormalities, not all of them, but for some of them. And that can be very helpful when you're trying to determine whether a gene is pathogenic or not. So if you've got a first-degree family members where each one who has symptoms is positive and those without symptoms are negative, then that makes it more probable that the gene abnormality is relevant and is the underlying cause. If, on the other hand, you have someone without symptoms who comes back positive, then there's a greater chance that that's not a relevant gene and it might be downgraded to a benign or likely benign at a future date. So genetics is still an interesting issue, and even at the most recent genetics EDS conference, which was just last month, there are still new genes being found. And that can take, an example was given, a patient had an obvious classical phenotype, and it took 7 years before the university genetics lab that she was working with actually found the underlying gene. So it's not always easy found. So if you've got a classical phenotype and your genetics come back negative, it doesn't mean you don't have EDS. It just means we don't know what the genetics are yet. That's really what it comes down to, because we don't know any of the genetics for the hypermobile types yet. So there's one gene under the spotlight for the hypermobile type, but it's not been confirmed, and it's only been found in a small number of the hypermobile EDS so far, but it's still under the spotlight. So yes, Invitae is very good. Then there's GeneDx, who does a 49 gene panel, also based in America, but a 49 gene panel is going to miss more genes as a result. And they're similarly priced to Invitae. It's just a case of who you choose. When you send to America, send with FedEx. If you send with someone else, you'll get returned at the American border. And 6 weeks later, you'll get the sample back again. So please send with FedEx. Invitae, with their kit, send out the FedEx paperwork that goes with it, so it's much easier to send.
Great, thank you very much. There's a couple of people who've asked questions about whether recession of gums is a feature of EDS and hypermobility. Yes,
there's a simple answer. So in particular, if you've got someone with markedly recessive gums, then you're thinking about hypermobile EDS on question 3, that's an indication that you really got to look for, is it the periodontal type of EDS? So periodontal EDS is one of the rarer types of EDS. But you can get recession of gums from other genetics as well. And it doesn't have to be just the periodontal genes, but it's not quite as extreme. So if you've got someone with abnormal gums, you do have to have better dental hygiene, more care, avoiding the sugary foods, cleaning your teeth on a regular basis, often with a fluoride toothpaste, but certainly cleaning your teeth. You can use salt instead. For someone's allergic to fluoride, you can use salt instead as to help clean the teeth. And dental hygiene is very important so that you don't get the teeth loss at a younger age.
Okay, thank you. There's a couple of questions about the compression syndromes. So a few people have highlighted that it's difficult to find physicians that can accurately diagnose these syndromes, and I think you did highlight that during during your presentation, and that in fact you can get different results from different physicians. And so do you recommend anywhere in particular in New Zealand or Australia that knows about and treats these, and just ask for the protocol name that you mentioned during the presentation?
Okay, so Thomas Skolbach and Wilhelm Sandman. Thomas Skolbach is one of the 3 people that was in the 2021 paper. So the American Journal of Medical Genetics Part C, December 2021. And he produced the protocol for the ultrasound of the abdomen, which is done both lying and standing, pre and post eating. And in New Zealand, we have one radiologist, Michael Swarbrick in Hamilton, who follows that protocol. We have another one in the South Island who has done a little bit of the protocol, but he's not regularly used, whereas Michael Swarbrick in Hamilton is regularly used. In New Zealand, we have a vascular surgeon, Chris Holdaway, who works in combination with Michael Swarbrick for making the diagnoses, and he will do the referrals as well. So Thomas Skolbach is in Germany, and he is very happy to chat with patients. Skolbach is spelled S-C-H-O-L-B-A-C-H. But if in doubt, look it up also in the American Journal of Medical Genetics Part C, December 2021, because they've got a whole paper on it there. Wilhelm Sandman is the vascular surgeon in Germany who does the operations, looking at all 4 at once. Occasionally, someone will only have 2 or 3. But if you're only treating one, and I know that there are some vascular surgeons in Australia who will only treat one, but you've still got the others behind, the patient's still going to have severe pain. So you actually have to treat all of them to get rid of the pain. Now, an important thing to note about vascular surgery is it only treats those problems. So if someone's still got gastroparesis, then they've still got gastroparesis. Also to be noted, it is major surgery. It is not minor surgery. When someone has open heart surgery, they can take a couple of months to recover from it. And they're people who have a good nutritional status before they go into surgery. People with EDS who have these vascular compression syndromes have had a limited, very restrictive intake because it hurts to eat. And therefore, it can take 2 or 3 times as long to recover. And the first month or so is a major difficult time to go through, and a very depressive time because it's hard to see the forest for the trees. And so that first month, you need to have really supportive people around you. But understand it can be 12 months later before you really see all the benefits come through. However, of my patients, most that have done really well. We've got one who's still struggling because her other gastric issues haven't been sorted yet.
I'm wondering if I might ask a question, Dr. Burling. We see in our cohort here in Adelaide, we have a POTS clinic, and we have a large amount of people with hypermobile spectrum disorders, including the hypermobile EDS, and we see a lot of mild to moderate scoliosis in that cohort. I'm interested if there's any research on that and whether that was a consideration for the inclusion in the 2017 diagnostic criteria. What's your thoughts about the relationship with EDS?
So the scoliosis is more common in EDS because you've got laxer ligaments. It's usually not a problem unless it's severe. I've only had one patient who's needed scoliosis surgery out of more than 1,000 patients, because without it, it would have affected her heart and lungs. But for mild to moderate scoliosis, it's not a cause of injury, but it makes you slightly more easily injured when you have an accident. The back injuries are still treatable with often the osteopathic techniques, and in our clinic, we combine the osteopathic techniques with strengthening injections. So we recognize that it is more common, but I don't aim to straighten a person's back from a scoliosis point of view. I only aim to treat their injuries and treat the underlying associated problems that come with it. I don't aim to treat the source. On the other hand, as you treat the injuries, many of them the back will straighten a little bit anyway as the ligaments tighten up. So that's just a byproduct of strengthening. Now, you have in Adelaide a good musculoskeletal physician, Ramona Chrysidis, who does PRP injections, which is a good form of strengthening. And when compared to the agents I use, tetradecal or polydercanol, it appears to be equal in its efficacy. So hasn't had head-to-head studies, but anecdotally, and by anecdotally, I've noted that everybody who's had PRP, I haven't had to treat that spot where they've had the PRP.
Interesting.
Because it seems to have done the same job. So, and I have watched her in her ejection techniques at a recent conference in the Gold Coast, and it's very similar to my techniques as well. So yes, she's very good. In Queensland, Bruce Jones is also does PRP, and he does some of the with tetradecal also. So he's good in Queensland. So there are two good Australians there to help you out with some of the strengthening injections.
Lovely, thank you.
Okay, we've had a number of questions come through about mast cell treatment. So somebody has asked, if you have stomach issues, is it reasonable to do a trial of a H1 and a H2 blocker to see if symptoms improve with this?
Absolutely.
Yes. Or would you try for sodium chromoglycate instead, or in addition to the H1 and H2?
So we've also got famotidine, which is a nice blocker. I prefer, so ranitidine was the best, but politics got in the way of ranitidine last year and had it removed worldwide. Unfortunately, there was a company in America who was producing ranitidine that was contaminated, but instead of just stopping that one company, they stopped it everywhere, which is a real nuisance. Cimetidine has the issue that it can aggravate and cause long QT syndrome. So it has to be used with much more caution. But famotidine doesn't have the long QT risk. And so it's the best that we have available for now. So people with reflux issues or esophageal dysmotility or gastric issues, they can respond well to famotidine. The reason why I don't like proton pump inhibitors such as omeprazole and pantoprazole is that they also block the absorption of calcium and magnesium and vitamin B12. So I prefer that they're used only short-term, such as treating H. pylori infections or for acute ulcers in the stomach, but not in the long term. That's my personal preference. That, of course, does have some benefit for mast cell issues, but I think we've got plenty of other agents that we can use instead of the proton pump inhibitors. Again, that's a personal preference, but I've seen too many people suffering. And osteoporosis in a young person in EDS is not that uncommon and has already been documented. And so if you're adding in a proton pump inhibitor, you're going to aggravate that osteoporosis. So that's my preference.
Okay, thank you. Somebody else has asked, if you are looking for a diagnosis of Ehlers-Danlos syndrome, who is officially able to give that to you?
Now, Australia has slightly different rules to New Zealand. In New Zealand, we have an excellent physiotherapist in Christchurch who has the Ehlers-Danlos clinic there, Anita Crawshaw, and she's got some good people with her. So anybody who follows the New York criteria can make the diagnosis. But I understand in Australia, there are some issues with politics about it being made by anyone who's not a doctor. So what often happens amongst the Australian physiotherapists and other allied health is that they'll say, we think this patient has EDS and these are the points in the New York criteria that they fit, and please go and see a rheumatologist who can help. So you've got the pediatrician in Sydney, Louise Tofts, who's superb and overworked. And then it's otherwise, if you go onto the Ehlers-Danlos site, there are lists of various specialists in not just Australia and New Zealand, but other countries as well who are able to help. And they do have a nice directory there for people that can help. Now, if you've got someone who you know who can help, whose name is not on there, submit it to them and they'll happily add it. So that's a way of people helping people to find out who's good near you.
And I think maybe on that point, we should point out that the criteria was actually set out for any physician to be able to use. So if they're familiar with it and comfortable with it, they can use it. And we are getting a growing number of GPs who are, coming to these conferences, webinars, attending the ECHO sessions. So it should hopefully, I believe you would concur with this, Fraser, that in the future we'd hope to see more GPs able to take this on as a diagnostic tool as well, as long as they feel competent and confident in assessing that.
We do have a few good GPs in New Zealand, and their names are well bandied about on the Facebook groups as well, who are very helpful. Unfortunately, as a result of that, they're also crowded in their waiting list too, but their waiting list isn't quite as long as mine.
Okay, somebody else has asked, have you noticed that people with EDS and infection may not always show the same large rise in their temperature as individuals without EDS?
It's a mild association that we've seen, but it's for some good reasons. If they're already on treatment for mast cells, then they're going to get a slightly blunted response. It doesn't mean they can't fight their infection, by the way. It means they may not go to over 40 degrees temperature. We're also seeing with long COVID, if you're on mast cell treatment, the risk of long COVID is much, much lower. And it's now recognized internationally that long COVID is most likely a mast cell issue, and treating long COVID with mast cell treatment. So it's actually easy in England to get sodium chromoglycate for long COVID and harder to get it for EDS. So, but yes, when you've got looser tissue, it's therefore you've got an area where the fluid's going to move more easily through that tissue. Infection can also move more easily through the tissue. You may get different responses to infection. We know that there are some types of EDS that directly affect the complement cascade. So C1q, C1r, C1s can be directly affected by some of the genetics of EDS. So we know that there are some issues there. We've also noted that there are other people with EDS who have other strange immune systems. I have one family where she had 3 of her children had multiple bouts of meningitis before the age of 1. So again, there are some rare genetics. We don't know what they are yet, but we do recognize that there are these strange immune reactions that can happen. And we don't know why yet. All we do is we treat them as we see them. And as we get data, we've got a greater chance of finding out the answer in the future. I mean, if we look at the 2021 information, most of that was not available in 2017. And that's we had indications, for example, in 2017 of an association between ADD, ADHD, and autism spectrum and EDS, but it wasn't confirmed. Likewise with the endometriosis, by 2021, it's now confirmed, and confirmed to be very significant. The celiac issues were noted. People with EDS are much more likely to be celiac. And when you take 100 people with celiac, a third of them are hypermobile. So we see these associations coming through, and we see other associations. So the infection risk and autoimmune risks, we're seeing those happening. And the more papers come out, the more information we get, the more we can therefore see, yes, this association is real. And these are how we can help people even better. So one of the things is not just diagnosing patients with EDS or their dysautonomia or their gastric issues. The second thing is now we've got a lot more treatment options available, which are really important. And so I often have new patients come to me saying, I was only hoping for a diagnosis and you've sent me away with so much more that we can do. Thank you so much. And that's just because you take time to listen to them. Yes, new patients do take a while. I have a 1 hour set aside, and then I have a lunchtime afterwards, and often I only get 5 minutes for lunch because I've taken nearly 2 hours for their consultation. That's common with EDS. They're very complex patients, but that's what we do because we're here to help patients.
Wonderful, thank you. Now, our final question for this evening, are you able to speak to the frequency and treatment for cranial spinal instability?
Sure. So back before 2017, Fraser Henderson is a neurosurgeon in America who was treating these with surgery. The problem is when you put hardware in the neck and 2 years later there's a new accident, it's a nightmare going back in. Since my publication in 2019, he's had someone do prolotherapy for treating around the occipital or nuchal line of the neck, so around the back of the neck, tightening up the ligaments. I've been treating that as well for a long time. If you tighten up those damaged ligaments, only 2% of the patients need to go to surgery rather than the numbers that were going before. It's a huge difference in outcome. And if you have a new injury 2 years later, you can go back in and repeat the prolotherapy again with no issues. So it's really then the person's ability to tolerate prolotherapy rather than anything else. So yes, it's for the injection therapies. When I'm doing them for my patients, it's normally 1 injection per spot for 9 out of 10 people, as in 1 in 10 will require more than 1 injection per spot, but 9 out of 10 people only need 1 injection per spot in order to tighten up the damaged ligaments and bring it back to what it was prior to injury. And we've seen the same with PRP, that it's 1 injection per spot in 9 out of 10 people. Occasionally people need a second dose without having a new injury.
Wonderful. Okay, sadly, there are more questions, but we are going to have to leave it there. It is midnight, as I understand it, in New Zealand, Dr. Burling. So thank you very much for staying up so late to share this wonderful and very informative webinar with us. We are very appreciative of your time and in sharing your knowledge with us. And the webinar will be or has been recorded, and it will be uploaded to the website for those of you that would like to go back and revisit some of the information that Dr. Burling has shared with us tonight. So on behalf of the Foundation, I'd really like to thank you, Dr. Burling, and everyone for joining us this evening. Please keep an eye out in your emails for evaluation forms, which does help us to plan our ongoing webinar series. Our next webinar, I will just bring up on the screen here for everyone, and this will be our final webinar for the year. And this will be held on Tuesday, the 28th of November. And it will be our Community Engagement Officer, Claire Clark, and Jennifer Smallridge, who's an exercise physiologist, who will be talking about everything you need to know about living with POTS, and keep an eye out on social media. They'll be asking for some questions that you would like answered during that webinar. And we're also very excited to announce that we will be holding a conference in Adelaide next year. And so this is following on from the conference that we had last year, which was just really for healthcare professionals. Next year, we're very pleased to be running both a consumer and scientific day. And so the 22nd of March will be a consumer day, and that will be held both here in Adelaide and online. And for healthcare professionals, there'll be a scientific day on the 23rd of March. So you can register your interest through the QR code just there on the screen, and we'll be opening up tickets for that conference next week. And finally, we'd just like to finish up this evening with a petition that we currently have circulating. We're looking to lobby the federal government to provide dedicated funding for POTS in the next federal budget. So as part of that submission from the Foundation, we're looking for as many signatures as we can to take to the federal government to help provide support for this. And so please, again, you can scan the QR code on the screen or look out in social media to support that campaign. Thank you very much, everyone, and we look forward to seeing you at our next webinar in November. Good night. Thank you, Dr. Burling.
Thank you.